Good evening, everyone. Dr. Deepak. Good evening and welcome to the installation, much awaited installation of Mongolia chapter. Dr. Deepak, you may carry on.
Welcome everyone. First of all, welcome to the ISM-ICS family, and we are happy that our Mongolian friends has started a new international chapter for us. Before moving abroad, I would like to take our blessings from our founder chairman, Dr. Amulya Sahu sir. Sahu sir, please few words.
We welcome the Mongolian chapter and we are very happy. Though it has taken a little longer than we expected, but it has come around. And we are now in almost 22 countries. So this is a new edition, makes us really feel rich. They are wonderful people and we have a wonderful relationship with this country. And so after welcoming, I want that Dr. Boramani to play the journey of ISMS ICS, and then we'll see.
Okay, thank you, sir. Let me show you what is ISMS ICS all about. I'll play a small video. Let me share the screen. Can you see my screen?
Yes, we can.
Yes, sir.
Yeah.
We can, sir.
Welcome to International Society of Manual Small Incision Cataract Surgeons. Scleral tunnel incision is a secure incision. There are newer advancements in SICS like 2 mm incision surgery, smart incision surgery. With customization of incisions, the astigmatism can be managed very well. SICS has become a premier surgery now. The International Society of Manual Small Incision Cataract Surgery was launched in 2005 in Mumbai. Dr. Amulya Sahu is the founder chairman of the organization and Dr. Jagannath Boramani is the executive chairman of the organization. The first international conference of ISMS-ICS was organized in 2005 in Beijing, China. The second international conference was held in Malaysia in 2007. This was a 3-day event with wet lab, live surgeries, and scientific deliberations. This was followed by successful conferences in Indonesia, recording in progress, in Egypt, Philippines, and South Africa. ISMS-ICS surgeons were invited to conduct wet lab in Asia Pacific Association of Cataract and Refractive Surgeons Conference in Kuala Lumpur in 2015. Dr. Boramani, as the first editor, published many journals of the organization in the past. The organization started holding World Conference every 2 years. The first Comprehensive Cataract Conference, CCC 2015, was held in Pune. The Aravind Eye Care System organized the second CCC in 2017 in Chennai. This conference witnessed the joining of Help Me See with ISMS-ICS for simulator-based training. An instruction course as well as wet lab were conducted in WOC 2018 in Barcelona. The ebook, Master's Guideline on SICS, was released during this conference. The organization has arranged multiple programs in partnership with various associations. The World Conference CCC 2019 was a 3-day grand scientific fiesta in Kolkata. The All India Ophthalmological Society started giving ISMS-ICS 2 big sessions in every annual conference since 2018. ISMS-ICS has now chapters in almost all states of India and across many countries in the world. We have started training on SICS simulator in partnership with Help Me See. The internet-based Global SICS training program was launched during AIOC 2022. ISM-SICS started the publication of journal again in 2022. After the physical launching in Egypt and Bangladesh, during the pandemic, chapters were launched in almost 15 countries. The COVID pandemic witnessed almost 50 webinars with massive attendance. ISM-SICS has got a women's wing to address specific issues of women surgeons. The Emeritus Society of Ophthalmology organized a 2-day hands-on training workshop in Dubai in June 2022. The Australia and New Zealand chapter was launched during the annual conference of the Royal Australia and New Zealand College of Ophthalmologists in October 2022. The 4th CCC was organized by PGIMER, Chandigarh, in November 2022. In February 2023, ISM-SICS conducted workshops and sessions in Emeritus Society of Ophthalmology Conference at Abu Dhabi. The UAE chapter also was launched. In 2023, chapters were launched in Singapore and in Nepal. ISM-SICS was also invited for a study tour in Vietnam. In October 2023, ISM-SICS was given a session and a live surgery in Annual Russian Ophthalmic Congress. Dr. Boris Malyagin announced the formation of Russian chapter of ISM-SICS. The 5th CCC was held in Hyderabad, jointly with LV Prasad Eye Institute. In February 2024, ISM-SICS again conducted a workshop, a wet lab and a session in ESO 2024, Abu Dhabi. In the same month, ISM-SICS was invited to conduct 2 wet labs and a session in APAO 2024, Bali. These are the forthcoming events of ISM-SICS.
Yeah, thank you very much.
Yeah. Thank you, sir, for that excellent ISM-SICS information video. Now I welcome all the chairperson, co-chair of this meeting, and we'd like to start our installation ceremony, the much awaited ceremony of installation of Mongolia chapter. So we'll start with our first introduction, President of the ISM-SICS Mongolian chapter, Dr. Burin Jarjagal. She is a clinical professor, master of medical science and cataract specialist. She is consultant ophthalmologist and former head of ophthalmology department at the first Central Hospital of Mongolia, Ulaanbaatar. I request our founder, Dr. Amulya Sahu sir, to induct Dr. Burin Jarjagal as the president of ISM-SICS Mongolian chapter.
Welcome, Dr. Burin Rangal. So, pardon me for if I'm not pronouncing it all right. It's a new kind of name, but you're most welcome to the family of ISM-SICS. Thank you.
Yeah, Dr. Burin Jarjagal, are you there? You would like to say a few words?
She's not connected now. She's still trying. Other all people is attending.
Yeah.
We can connect with her later when she connects.
Sure. I will teach her.
Yeah. So coming to our next Vice President of ISM SIC's Mongolian chapter, Dr. D. Enkazur. She is a consultant ophthalmologist. She has done Master of Medicine, Cataract and Medical Retina Specialist at the First Central Hospital of Mongolia at Ulaanbaatar. Dr. Enkazur, are you there?
Yes, I am here.
You would like to say a few words here?
Nice to meet you, all of you.
Yeah, I request Dr. Jagannath Boramani to install Dr. Enkazur as the Vice President of the ISM SICA chapter.
Yeah, I declare that Dr. Intstallation is installed as Vice President of Mongolia chapter of ISM SICS.
Congratulations, Dr. Enkazur.
Yeah. Nita, make it full
Thank
screen.
you.
Okay.
Correct.
So next, the chairperson of ISM SICS chapter, Dr. Enkazur. She is the head of ophthalmology department, cataract and surgical retina specialist at the First Central Hospital of Mongolia. I request Vice Chairman Dr. Parikshit Gopte to install Chairperson Dr. S. Enkazur.
Thank you for introduction. Hello, good evening, everyone.
Good evening.
Your video.
We are all, yes, Mongolian team, we are all happy to be and join, having you all here. Thank you so much for supporting us to start ISMSICS chapter in Mongolia. Thank you so much.
Let's
Yeah.
Saucer install.
Dr. Saucer,
Doc-
I request to
Dr.
install.
Yeah,
Gopte,
welcome,
please
Dr.
out.
Antotul. And we are very happy to install you as the chairperson. So we will have regular communication on SICS promotion in your part of the world. So welcome to this family.
Thank you so much. I'm so happy too.
Yeah, congratulations, Dr. Enkazur. Now moving forward to the inducting as the Secretary of ISM SICS Mongolian chapter, Dr. Undarma, who was really helping and forming this chapter and also helping to easy pronunciation of all the doctors. Thank you, Dr. Undarma, for all the help. She is a consultant ophthalmologist. She has done the Master of Medical Science, Cataract and Cornea Specialist at the First Central Hospital of Mongolia. I request Dr. Boramani sir to induct Dr. Undarma as the Secretary of Mongolian chapter.
Yeah, I declare Dr. Undarma as Secretary of the Mongolia chapter of ISM SICS. Welcome to the ISM SICS family.
Thank you very much for inviting us. And this is a wonderful opportunity. And we are very happy to hear and joining this chapter.
Yeah, thank you. Thank you.
Thank you so much.
Dr. Undarma, and congratulations.
Thank you so much again.
So moving forward for the installation of Scientific Committee member, Dr. E. Inkazaya. She is a Master of Medical Science and Glaucoma Specialist, and she is a consultant ophthalmologist at Third Central Hospital. I request Dr. Sahu sir to induct Dr. E. Inkazaya.
Good evening, everyone.
Good evening.
Good evening. Welcome to this family, and we'll be very happy to interact with all people.
Thank you for ISMCIS.
You are doing SICS or not?
Yes, I'm doing.
Yeah, good. So you see our videos and interact with us, and maybe we can have a live surgery in your place and have a tour of your place. We can plan it if you are interested.
Okay, I will see. I'm interested.
Your country looks to be beautiful in the picture, so let us see. We can look forward. Okay.
Dr. Undarma will be sharing her country's video with us, sir, in short time. Congratulations, Dr. Ekjaya. Now moving forward for the next scientific committee member, Dr. Baya Setsak. She's done her Master of Medical Sciences and she's a cataract specialist. She's head of ophthalmology at 3rd Central Hospital, Ulaanbaatar. Dr. Bayat said, sir, I request Dr. Boramani, sir, to
Deepak.
Dr. Deepak.
Hello, everyone.
Hello.
Hello, everyone. We are so happy to join in this society, and we hope so long to help us in corporations.
Yes, Jagannath.
Yeah, I declare Dr. Bayat Setsing as scientific committee member of Mongolia chapter of ISM SICS. Welcome to the ISM SICS family. And congratulations.
I think Mongolia, the ladies are really liberated ladies. Advanced, very good.
Female dominance in ophthalmology in Mongolia.
Yes.
Are there any male doctors or no?
That's
Yeah,
really
80.
true.
80% of the male doctors.
Okay.
Most of
80% are ladies.
yeah, ladies.
Wow.
Yeah.
That's, I think, a very open society, looks like. Because in our country, we keep our ladies much ahead of everybody. So our ladies are very advanced. Advanced at the same time, very traditional.
So this is the installation or ceremony of Mongolian chapter. I congratulate each and every member, and we look forward to have a great association with you, learning and teaching as well. So moving to next, coming to the academic part of the today's session, I welcome our discussant, Dr. Buren Jagral, Dr. Varun Nayak, and Dr. D. Ekuzil. Now I invite our first speaker of the session, Dr. Parishik Gokte. He has a very long CV. He has done MS Ophthalmology, DNB, FRCS, Edinburgh, and he is ex-IPS Gujarat. He has done a FICO Fellowship in Pediatric Ophthalmology. He is a Vice Chairman of ISM SICS. I request Dr. Parikshit to speak on significance of manual SICS in addressing cataract in North Asia. Dr. Parikshit. Please share your slide.
Yeah, thank you. Thank you, Dr. Neeta. Can you see my screen?
Yes.
Yes.
Okay, so this is at the outset, I would like to thank our chairpersons, Dr. Sahu and Dr. Boramani, and Dr. Enkul and Dr. Undarma for getting us all together and for starting the Mongolian chapter of ISM SICS. Dr. Undarma is showing us a beautiful video of Mongolia. It's a huge country and very, very cold country with very warm people. I remember their enormous hospitality when I visited it 6 years ago. And it's a huge country which sits between even two huger countries, between Russia and China. And they have influence from both, but they have their own this. And as an Indian, as I was very happy and proud to see that there is a lot of Buddhist influence there. So before I start about how ISM SICS can collaborate and how SICS can help with Mongolia, I would just like to quote a few studies that have come from Mongolia. The first clinical hospital's blindness survey. In fact, when I was at the International Center for Eye Health, Moorfields Eye Hospital, Gordon Johnson was our dean, and he had done most of his work on angle closure glaucoma in Mongolia. So he had very, very fond memories, and he would always show slides of Mongolia. And there, the prevalence of blindness in Mongolia was very high about 30 years ago. And compared to other countries, the climatic droplet keratopathy was very high because of the population, which is of cattle breeders and nomads. And because it's at a very high latitude, there is a lot of UV radiation. And cataract and glaucoma accounted for almost 35% of blindness. So glaucoma is very, very high compared to our country where cataract forms more than 50%. Again, this is another landmark study from Mongolia, where they looked at the prevalence and the causes of visual impairment and blindness in children. And it's perhaps the only study on childhood blindness, which is from general practitioners, from schools for the blind, and by doing a prevalence study. And here they had shown that the prevalence of blindness in children was about 0.2 per 1,000. And again, 1/3 of this blindness was because of cataract. So even that is very high. And in fact, we use this study as a base study for all the schools for the blind study that have been done in other parts of the world. And my mentor, Dr. Claire Gilbert with Dr. Balgan, has been the author of this. While there is data from Mongolia, Outer Mongolia, Inner Mongolia, which is now a region of China, there also the prevalence of blindness was about 4%. And the main cause of blindness and low vision was again cataract. Again, when we look at epidemiology of age-related eye diseases, there is a lot of data that is there on refractive errors and glaucoma. And a lot of that has come from India, Taiwan, Mongolia, Singapore, and Japan. So the Mongolian contribution is very much there. In fact, when they looked at various screening methods for screening angle closure glaucoma, since most of the research for angle closure glaucoma started in Mongolia. So in the Greenland, in the Inuit, which have a very high incidence of ACG, and in Mongolia, again, where ACG is very, very high, they have used different techniques to find it. In fact, if we look at all the projects for the angle closure glaucoma, occludable angles, angle closure, and blindness from ACG, all of that has come from the Singapore and the Mongolian data. And again, in this angle closure glaucoma, while laser PBI is perhaps the mainstay in India, because in South India, we have a lot of ACG. Again, for novel treatments, one of the novel treatments for angle closure glaucoma is cataract extraction. And that is, I think, where our Society of Cataract Surgery, of Manual Small Incision Cataract Surgery comes into being. We all know that the cataract is the leading cause of blindness. It is much, much more so in Southeast Asia as compared to North Asia, because in North Asia, glaucoma and refractive errors, myopia, is much, much more common, but cataract is still very much there. And if we look at the analysis of cataract surgery services, then if we look at the total number of cataracts that are there, which are forming, surgeries that have been done, and cataracts which remain at the end, we have what is called as cataract surgical coverage, which is how many people who actually need surgery, how many of them were operated upon. So this is a study that we have done in Nepal, again, a Himalayan cold mountainous region, a bit akin to Mongolia. There also, untreated cataract is the chief cause of blindness, the chief cause of severe visual impairment, and the chief cause of moderate visual impairment. So at the 360, the 660, and at the 618 cutoff, it is the commonest cause of blindness. But when we look at the cataract surgical coverage, here the cataract surgical coverage for the country looks quite good. It is about 82%. But if we look at the effective cataract surgical coverage, how many actually got better than 612 vision, then it's just 35%. So which means that the quality of surgery needs to be improved. So Mongolia is a vast land with scattered people. So when we say barriers to cataract surgery, we traditionally have 4 barriers: lack of awareness, bad service, cost, and distance. And in Mongolia, because of its huge distances and a population that is spread across various regions, the barrier of cost and distance is very, very important. Like last week only, Dr. Underma said she had gone with a team to the Gobi Desert, the Altai Gobi area, and there, it's very few services that are available. So again, when we look at barriers to cataract surgery from Nepal, one is, of course, the cost, but another major barrier is need not felt. people believe that, well, why do they need to undergo cataract surgery? As they become old, perhaps having less vision is normal. So this is a fallacy that all of us surgeons have to combat. Again, from Bangladesh, if you see, prevalence is much, much more. And it's not just how many cataracts are there, but what is the outcome that we give. So ideally, according to the World Health Organization, we should have 90% having better than 618 vision after cataract surgery. So today, phaco is like the king of cataract surgery. It's the surgery of choice all over the developed countries, the US, Europe, and most of the urban centers in India, and like we saw in Ulaanbaatar in Mongolia also. But manual small incision cataract surgery, where a scleral tunnel allows a sutureless surgery, reduces astigmatism, and improves unaided visual acuity, is economical surgery. It can be done anywhere, and it's a great surgery in its own right. In fact, when we had done a meta-analysis comparing phaco and SICS, we had found that there is no great difference in both the techniques. At the 6/9 cutoff, phaco definitely gives better unaided visual acuity. But then for all other things, complications, endothelial cell loss, there is no great difference. And even though the astigmatism in phaco may be much lesser, the near unaided vision is much better as far as SICS is concerned, because the small astigmatism actually helps for good near vision. Again, the time taken for SICS is much lesser. The cost, of course, is much lesser as compared to phaco. And my friend, Dr. Deepak Mishra, who's professor, will be telling us how we can take SICS from 8 millimeters to up to 2 millimeters. So both of them are comparable. Each has its own merits. And when we look at the Mongolian scenario, with the new Mongolia chapter of ISMS-ICS, we are looking for more collaboration with our Mongolian friends and colleagues, collaboration in academics, collaboration in research, because there is so much work that is done in Mongolia, but so little of it is published. I mean, in the last 25, 30 years, handful of publications. And ISMS-ICS has its own journal, the Global Journal of Cataract Surgery and Research, the GJSRO. And today we have two of the editors, the chief editor, Dr. B.K. Nayak sir, who is here, and another associate editor, Dr. Aarti Heda, who is here. So I would request our Mongolian friends and colleagues to contribute to this journal so that we can take this journey of cataract surgery further ahead and give sight to our patients. Thank you. Thank you for your hearing.
Thank you, Dr. Parikshit, for excellent coverage of cataract analysis area-wise in North Asia, and also the surgical coverage, importance of SICS.
Parikshit, can I just have a word with you?
Yes, sir.
You have a recent multicentric study and say that unaided visual is better in phaco than SICS. I think you have to do a real reassessment again. We are definitely better unaided in my experience. What I'm seeing, because this phaco they are doing sort of cornea handling and immediately maybe you see a little better, but subsequently we are giving more unaided vision than phaco. A time to reassess your presentation, because now you are having a authority in this kind of presentation, so it is better you have a multicentric study, and it will be really world over, people will appreciate it. You are following the old assessments, because that time everybody was doing SICS for just for cataract delivery, but they were not focused on having astigmatism correction and other things. Now things have changed. Okay, because your meta-analysis has to be now reassessed, revisited.
Yes, sir. We need to add more studies because the meta-analysis was published in 2015.
Let
Looks at
ISMSICS design this study, na?
Sure,
Under your
sir.
supervision. I think we can
Sure.
tie up the institution and do an ISMSICS. I think and we can involve the foreign people also in this process. It will be a real huge thing, you know. I think next project of yours is this meta-analysis and something and multicentric study. Okay.
Yes, sir.
One second for this kind of result is that time.
Deepak, voice is down. Deepak, your voice is down.
Sir, one of the reason for this type of study means where FEPO is having better 6-9 vision at that time is because we have less number of literatures on the MICS. That is the reason, because when we are comparing with that, I even read the paper of the Boramani sir and the Parikshit sir. Both of them are having higher number of FECO presentations. Means one of the lacking was there, the data of ISMIC, data of MICS in the published literature. But nowadays, since we are having our own journal and we are publishing more and more in the literature, even in the last year in the IGO, now things are changed, sir. If we do some more research or track more articles on that, then I think we agree with you that at least for 6-9 there is no difference between SICS and MICS. But at that time there was less number of published literature. That's why these kind of results were there.
Thank you. We'll move forward with our next talk by Dr. Deepak Mishra. He is Associate Professor at Regional Institute of Ophthalmology, Varanasi. He is member AIOC ARC Honorary Secretary of ISM SICS, Chairman ARC UP SOS, and Honorary Secretary of BOS. With this short introduction, I request Dr. Deepak Mishra to speak on journey of MSICS from 8 mm to 2 mm incision.
Thank you,
You may
Dr.
share your slides, sir.
Yeah, please. Thank you, Dr. Nita, for the introduction. Is my slides visible?
Yes.
Okay. So first of all, I would like to again welcome our colleagues of the Mongolia, and we are happy that we are going to associate with you and have, as the Dr. Parikshit already mentioned, that we are having a trying or we have to try that we will have a better collaboration in the field of academics and research. So I'm going to present the journey of SICS from 8 mm to 2 mm. There is no financial interest in it. So why to shift means what is the reason, what are the factors that push us from lot of the times that we shifted first from the ICC then to ECC. One of the important thing when we shifted from ICC to ECC is we want a smaller incision site. Again, we want to place some IOLs in the posterior chamber or the anterior chamber so that we can have a better vision, decrease the losses of the vitreous so that we have less complications, and also the less deadful complications like RD and PBK to prevent it. So that was the reason when we shifted from ICC to ECC. But again, our goal changes time by time from ICC to ECC, and now from ECC, in which we are doing SICS, now we shifted to MSICS. And the reason for the manual small incision cataract surgery are shifting for this is the three reasons why we go for it. One is the astigmatism management, means larger incisions have larger astigmatism, and another is the reduction of the size of the incision. These are the two parameters which help us to, or which is the demand of the time we can shift from there to there. But why? What is the major problem?
Your slides are not moving. Give a slideshow.
It's moving from my side.
Yeah, make it full screen.
Full screen, yeah.
Sir, it's full screen on my side.
Yeah, no, we can see only the first slide.
Yes. Yes. Just a minute. Shared and again, what you say?
Double click the first option.
Screen. Yeah. Now it's in. Oh, now it's moving.
Yeah.
We can see the current slide now. Changing
Yeah.
goals. Correct.
Now
correct.
it's moving. Okay. Thank you. So the change for that time or the demand of the time is to have a less astigmatism and less incision size. But the problem with us means whatever we face as an ISMICS surgeon is how to remove the nucleus, which is approximately in the adult around the 10 cm of the size and of the this diameter, means ideally 4 to 6 micron of the diameter from a 2 mm incision. Means our incision site is 2 mm or 8 mm or 6 mm, but the nucleus, this diameter is much larger than that. So for that, we have to know that there is a anatomy of the limbus perfectly, means on which incision or where we can give incision so that we can reduce the astigmatism and the other thing. So first of all, I'm covering the two. First, I'm covering the two things. One is the astigmatism, means how we can have a neutral astigmatism with this type of the funnel. So there are various masterminds which work on it and to find out which incision we have to give to reduce the astigmatism. Like if you are giving a parallel astigmatism, then there is parallel incision, then there is chances of the higher number of astigmatism and higher wound gapping as compared to the frown incision, which we are giving here. Again, there are the various incisions, means in which we have a least number of astigmatism when we give the incision of the chevron types to the smile types, what we have given like that. We have to know that there are various uh, masterminds like Boramani sir has devised some of the astigmatism markers based on which if we go for that, then astigmatism is reduced gradually. So with this type of making slight change in the incision and the use of our different markers and the things, new techniques, we can reduce the astigmatism in the SICS. Another is here you have seen it steps of the traditional SICS where we are making an incision size which is almost 8 to 10 mm initial and then go step by step. I'm not going in detail of it, but these SICS gradually shifted to a smaller one. And with the help of the management means how we can deliver a nucleus into the part wise. And one of the initial technique was the snare technique. In this, what we can do, we divide the hard disk of the nucleus into the two parts. Means if this is the nucleus, we go by the snares and we divide it or cut it into the two part and then remove it. Here you have seen the incision size, means this is the nucleus, and with the help of the snares, we first divided, means remove the half part of this nucleus, and with again we make it elongated and cut it another half. So by this, with a smaller number of incision size, means a smaller size, which since divide the nucleus into the two halves, so we can deliver it from a smaller part. Then there was a technique which is a phaco fracture. Here is we can remove, what we can do is in this tunnel we bring the nucleus to the tunnel and half of the nucleus in the AC and half engaged in the tunnel. We put your upside, we put the upside pressure and divide it into the two parts. Means half of the part or the half of the nucleus has been removed. You have seen that this part of the nucleus is removed. Then again hold and engage the nucleus in this tunnel and do the fracture. One of the more, this was a technique in which we are using the phaco fracture. We can go either in a two step or the three step. This allow us to give more removal of the smaller parts into two or three steps. And again, by since we are removing the nucleus in a divided part, we can divide it into the many steps. Then there was a Dr. Raut technique which we described into 99, which we have divide this into the temporal scleral tunnel with the straight incision. He created what even he has done with the help of the side port and the V incision. He removed this and removed with the help of the hydrodissection with this expression. Dr. Raut also planned or have a software which help us in reducing the pre-existing astigmatism in the cataract surgery. With the help of this, he also published it in the Indian Journal of the Ophthalmology. And the revolutionary step was the Dr. Sahu's technique, in which he divided. What he has did, the initial incision is 2 mm, but he give a again an scleral incision vertically from that to the behind. So initial incision what we are required is again 2 mm, but this incision is more. So here you have seen with the help, you have to remove the cataract with the help of only the 2 mm of the initial incision. Leave this the fornix which is having the higher, move to the higher incision. So we have seen with the help of initial SICS, means where we are going to do the SICS surgery with the 8 mm, then the with the help of the snare or the divide technique into the smaller one, 6 mm, 4 mm, and now we are doing it with a 2 mm. And the beauty of this type of surgery is that we did the study on that, what is the effect on astigmatism or the visual outcome, and it is again published in the Indian Journal of Ophthalmology last year in year 22, 2 years back. And here we will concluded that whatever we delivered, we have what just Sahu sir said, we have a good visual recovery. Means visual recovery with 2 mm is as good as like the phaco, and it also have a low astigmatism. Means since we are using only a 2 mm of the initial astigmatic tunnel, which is little bit a astigmatic zone. So with this technique, we have a lower astigmatism and good visual outcome. With this word, I would like to thank you all for your kind listening. And it's my advice for all SICS surgeon who are doing, just reduce your size small by small and have a practice to remove the nucleus, in the divided part. Thank you, sir. Thank you, everyone.
Thank you very much, Dr. Deepak, that elaborative session on reducing the size from 8 mm to 2 mm. We have a master of 2 mm incision, Dr. Sahu, sir. Sir, you would like to say something about this? Sir, unmute. Sir, your voice is not. Unmute, sir.
See, 2 millimeter is definitely the future of SICS. And as the more people professors get involved, the students will start learning it. So if you are doing a scleral incision 2 millimeter, now that would be a good challenge for the phaco surgery. And now phaco surgery, they are involving the cornea, which is long-term creating a lot of problems, which SICS will not do. So I feel that professors like Deepak Mishra and Karamjit Singh and so many people are now get practicing, and some people have also taken thesis paper on this. So this should be the future. I think they have to focus on see that we do a totally bloodless surgery. That will be our focus there. And instrumentation has to also refine whatever I have done, and Deepak and other people should focus more on this to find out more better type of instrumentations and other things. So this is the future, and all over the world, people have to learn this thing. And my friend, our chairman, the executive chairman, his method also, his algorithm and other things. People should see that how to modulate the modulation of wound will take away the astigmatism. It's a really a wonderful contribution, and people should feel proud to do SICS. That earlier that they were diffident to tell that they are doing SICS, that inferiority complex should go. It is a wonderful, it is an art of cataract surgery, and if you have the skill in your hand, which is you learn phaco, but you must have the skill with you. Whenever the phaco fails, you are not failing. That kind of thing, you have to become a complete cataract surgeon, not a phaco or SICS surgeon. So every surgeon must master both these techniques. Art is always valued more than the science. They have their place, but art is you enjoy your magic in your fingers. So that is what I will say, that create magic in your fingers and master the machine. That is okay. Yeah, Undarama, am I right or not right?
You're right.
Yeah, ladies should always go for this art.
It's a great topic. Thank you so much. I would
Yeah.
like to share my experience in 2.5 millimeter scleral tunnel incision. When I do secondary scleral fixation yawl using PNL N-Vista foldable yawl, I usually do 2.5 scleral incision, millimeter scleral incision. So we will try to, we will focus on that to minimize our scleral tunnel.
No, there is a science involved now. Dr. Nilutpanna Deuri has done the research on this thing, on the physics of the wound construction, and you can follow her, and you can be in touch with us, because the wound construction is totally different. Unless you follow that guideline, you might be thinking that you have done a 2 millimeter, but if your back cut is tangential, it never remains 2 millimeter. It becomes about 4.5 millimeter. So you have to see whether you are giving a tangential cut or you are having a parallel cut. And plus, there are other instrumentation has to change. You have to. I have done a lot of improvement on the instruments, so you can try to get those instruments if you are going smaller incisions. It would be helpful. And I am dividing the nucleus now in the bag. That also you can see through my videos. I can share videos with you how to divide the nucleus in the bag. So it is almost nearer to phaco and better than phaco many a times. And result is superb. If you don't have astigmatism, you are not creating any astigmatism with 2 millimeters. So that, and if you are knowing that how to modulate the wound, and there you can make any number of, I think Dr. Boramani has done a lot of work on that. 3-4 cylinder you can just remove with incision. So,
Okay.
So that is a wonderful thing. I think with the community increasing, we should now focus and share papers, publications, and other things. You go through our journal recently. That it was a cataract-oriented journal, SICS, dedicated to SICS. So there you will find a lot of papers. You can follow it. If you are going 2.5, it is better you share your video and see our video. We can communicate on that.
Thank you so much for sharing.
Yeah.
Thank you so much for sharing your knowledge and skill. Yes, we will have a lot to learn. Yeah.
Yeah. Thank you, sir. So here is one small request for all the participants. Please start your videos. We'll just have one picture. Start your videos with a big smile. We'll have a memories of this webinar. Everyone, Udama, if you can ask in your language.
Одоо бүгдээрээ зураг авахыг инээ. Тэгээд нөгөө зураг түүх өгүүлдэг учраас бүгдээрээ камера өгчүүл сайн байна.
Yeah, thank you everyone. Smile please. Thank you. Thank you very much.
Thank you.
So with this good scientific information, we are moving forward for our next talk, which will be given by our recently inducted secretary, Dr. Undarma. She'll be speaking on cataract surgery in narrow angles. Dr. Undarma?
Yes, thank you very much. Can you see it?
Yes, we can see your slide.
Okay.
Yes,
Now
we can see.
Now it's moving?
Yes.
Okay,
You can,
Thank you very much. Good afternoon and good evening, everyone. Thank you for giving this wonderful opportunity. I'm Underma Tumurwatar from the 4th Central Hospital of the Mongolia. I'm a cornea specialist. Today, I would like to talk about the cataract surgery in the nerve angles in the Mongolians. The prevalence angle closure in the Asia, the global pooled prevalence, the acute angle closure was 0.7% for the last 20 years. In Asia, especially in the found, we have a highest prevalence of the primary angle closure glaucoma. The current estimated the population with the primary angle closure is the 17.14 million for the people older than 40 years worldwide, just 12.3 million in the Asia. In the future, in the global population with the primary angle closure will be 26.26 million, especially in the Asia. 2024 in Dr. Kim's meta-analysis study was shown the Myanmar and China. Myanmar and China, Japan have a high prevalence of the primary angle closure glaucoma in the over the 40 years old people. Also, next slide is the 2005 study showed that the univariant linear regression AC depth indicated it was the significantly shallower by 0.9 millimeter in the Mongolians, was lower in the women, especially in the declined by 0.1 millimeter at the decay. In the Mongolians, and the next chart is the Mongolian pass rate appeared to increase only below AC depth in the 2.40 millimeter with the passes, and also 19 millimeter was the 6 times higher in the Singaporeans and 18 times higher among the Mongolian people. Also, AC depth is the 1.79 millimeter in the less. The or of the pass had increased the 16th in the Singaporeans and the substantial in 174 in the Mongolians. Also, this slide about the peripheral anterior synechiae in the Mongolian, it showed that the gonoscopic angle wide was graded the 5 categories by the Schafer's grading system. Secondary pass were excluded. The odds of the pass were higher in the people with the nerve angle in the Mongolia. Also, in interstitial weave, the primary angle closure becomes the significant possibility in drainage angles of the less than grade 2 in the valid in the East Asia. Next tablet is showed the glaucoma was diagnosed the 128 subject. Among the people is with the pass had the glaucomatosis of the neuropathy compared with the without the pass. Also, this slide is our department ongoing data research. We concluded they used the data as of the 636 patients who underwent the cataract surgery in our hospital between the January to June 2023. This study mean age was the 63.6 age, and male and female radius was almost same, and the 89 patients were diagnosed with angle closure. Also, 12 patients were treated the phaco emulsification surgery for acute angle attack. Also, phaco and the small incision radius was 8 to 1. In our study, mean axial length was slightly longer than previous study. This slide, we compared the global ocular biometry with the Mongolian ocular biometry, and Mongolian Myanmar eyes also showed the shorter than the East Asian countries, especially in angle closure, patients were much shallow of the axial length in the Mongolia. There is one old thing in the recent study in the China study showed that the eyes were longer than the previous study. Also shown the Mongolian as anterior chamber is shallow compared with the other studies, and also PXF patient AC depth is 2.31 millimeters, and Mongolian Myanmar eyes are showed shorter than East Asians. This is our different study in 2017, and proposed was the efficacy of the fecal emulsification on intraocular pressure in early management of the acute primary angle closure after aborting in the acute attack. We conclude the symptoms of the sign of the acute angle closure attack and the intraocular pressure more than 22 millimeter mercury. We did the statistical analysis by the SBS. The result shown mean age was the 59 years old, and this condition is male patients are rare than the female. Mostly of this patient came to our hospital from the rural area because of the duration of symptoms is longer than people of the urban area, has more complicated with the posterior synechiae or corneal edema. Also, they used the glaucoma medication for the 12 days. After the surgery, mean time of the without glaucoma medication was almost 6 months. The result was those patient intraocular pressure was decreased to normal range after the post-operated day 1 and stable until 3 months. Visual acuity was increased at the post-operated day 14. In conclusion, our study result were the primary fecal emulsification cataract surgery for acute angle closure attack in the effective and safe method to reduce the intraocular pressure. It is the first line treatment for the angle closure attacks with the cataract cases. Consideration in the angle narrows eyes, we avoid to perform the parascents on the limbus because the iris prolapse happens to a lot of during the surgery. Especially in the AC, it was a shallow. We usually don't use the AC mentor, but the capsular access is performed by cystotom instead of the capsular forceps. Important thing is the PXA patient when we do the cataract extraction by fecal emulsification. Also, we consider that the power is exerted at the low setting and catching capsular bag to release the patient using the iris hook to prepare for the zonal dilatation. Sometimes air bubble is left at anterior chamber at the end of the surgery as the tamponade to prevent the volume from the shallowing. Also, we have a lot of corneal clutter cases where done the fecal emulsification surgery. It was the one of the challenging cases due to corneal deep senile arcus and the nerve angles. Additionally, malignant glaucoma incidence is the higher angle in the closure, but these cases was recorded a few in our hospitals. This cases was the angle narrow and the severe corneal scarring. We choose the small incision cataract surgery instead of the phaco. This is our patient has a corneal scarring due to the infectious keratitis with the brown cataract. We performed small incision cataract surgery to this patient because they avoid of the several complications. This is my last slide. In the Mongolian axial length of the eyes is observed the shorter than other Asian. Also, anterior chamber is shallow. Perceived exfoliation has a relatively higher prevalence and is often associated with the primary angle closure. Open angle glaucoma occurrence is less than the angle closure. Also, we prefer the cataract surgery for patient angle narrow with the cataract. Without the cataract patient, we always recommend the LPI or SPI. Thank you for attention.
Thank you for a wonderful presentation, Doctor.
Thank you so much.
Dr. Udarma, you wanted to show a video of...
Sure. This is a part of the Mongolian video.
Welcome to our home.
Okay.
Mongolia.
Please wait. Can you see it?
We can see it. The audio is not.
Make it full screen and play the video.
Okay, sure.
Play it.
Welcome to our home, Mongolia.
Full screen.
Ancient country, rich in culture and nomadic heritage. Welcome to our home, Mongolia. An ancient country, rich in culture and nomadic heritage. A young nation, where 65% are under 35. We treasure our unspoiled nature and proudly uphold our commitment to democratic freedoms. Our abundant clean energy is unlocking a brighter, more sustainable future. And new development programs ensure we stand tall as Asia's next leading power. Through rapid digital transformation, we're diversifying our economy and streamlining public services. We can now access over 800 services with the touch of our finger. Come to Asia's heartland. Come to Mongolia, where possibilities and exploration await.
That's a beautiful video, Dr. Udama. Thanks for sharing.
Thank
Beautiful.
you.
When are you calling us? You're saying come to Mongolia.
Okay. Welcome to Mongolia.
Yeah, thanks. Dr. Barun Naik, any discussion on the topic in narrow angles, the cataract surgery?
Yeah, good evening, everyone. She has covered the topic very nicely, and especially because in that country, in India also, where the angle closure glaucoma incidence is a little higher as compared to the Western country, but in Mongolia, in China, Singapore, it's still higher, the angle closure glaucoma. And whatever she concluded at the end, that if acute attack, definitely there is no second thought about it, that control the intraocular pressure. And if it is with cataract, then definitely do the cataract surgery. And if it is not cataract, no cataract, then one has to really think and do, as she also said at the last point, that either surgical peripheral iridectomy or the laser peripheral iridotomy. And otherwise, the only one some confusion is about if there is no cataract and angle closure glaucoma. But in that case, it's really one has to think only if lens is the cause, like either lens vault is high or the lens thickness is very high, and that is occupying so much space and pushing everything forward. So there probably it has got much more, the role is more in controlling intraocular pressure in future. But and if cataract is there, then definitely the cataract surgery can be planned little early as compared to the normal population. Suppose whatever the cataract, if you think cataract is very early and we should not do surgery in normal population, but if person is having angle closure disease, then definitely this is the indication that you will take a call little earlier. So thank you very much, Professor Undarma. Thank you. It was a really fantastic presentation.
Thank you very much.
And really because you have got very.
Yes, sir.
Dr. B.K. Naik is the past president of AIOS, and he is the present president of the Glaucoma Society of India and authority on glaucoma. So you are listening to B.K. Naik. He is a highly admired teacher of glaucoma.
Thank you, Dr. Amalya sir. Thank you.
Thank you, Nayak sir, for that important inputs on narrow angles. Now we move forward for our next talk. I invite today inducted Mongolian Scientific Committee member, Dr. Engzaya, to speak on cataract surgery after superficial keratectomy.
Oh, good evening, everyone. I changed my topic.
Okay, yeah.
I regret to inform you that there was been a last-minute change in my topic. I am prepared to present the case that I performed yesterday, but that is not the SICS case.
Okay.
Let me share my video. Today's topic is photoemulsification in white cataract. White cataracts are challenging at numerous points of surgery, challenged with reflexes because there is no light reflex. And increased intralenticular pressure makes the anterior capsule increasing risk of reflexes run out. Also, we know the Argentinian flag sign is a potentially dangerous situation. So this is the Argentinian flag sign. And capsular stain with trypan blue, initial puncture into the anterior capsule with the cystoton followed the immediate aspiration of liquefied cortex through the cystoton needle helps rapidly decompress and the cataract and decrease intralenticular pressure. The initial cut should not be initiated with forceps as a large cut can be uncontrolled and result in a rapid runout. Misgive fluid released in AC and aspirated after decompressing the lens. And hydro procedures in major white cataracts that have a large nuclei and less cortex and hydro dissection may result in the fluid wave being trapped behind the nucleus. Hydro delineation don't need to attempt it as there is generally no epinucleus. Capsular block syndrome, injection of fluid can cause fluid to build up within the capsular bag, resulting in capsular block syndrome and the capsule blow out with resultant risk of drop of a large nucleus into the vitreous cavity. And after the rexis, the next challenging step is the white cataract is nucleus removal. The capsular rexis should be made large enough to allow for generous moving and sculpting the nucleus. The entire cortex is opacified and there is very little epinucleus. The nucleus of the white cataract is large but generally standard nuclear disassembly technique may be used. Vertical chop works well for those cataracts. IA is generally not required in these mature or hypermature cataracts, and simple irrigation with the cannula often suffices. IA is done with the care for any residual cortex wisps using very low vacuum since the capsular bag is floppy and zonal thick. Thank you for your attention. I had prepared the different presentation for the topic because we didn't receive a specific information about the webinar. Sorry for the different topic and had not enough time. Thank you for attention.
Thank you for the showing the wonderful video and even I can say the needle technique with using the needle capsulorhexis in hard cataract itself. It is a difficult step, and whether it is phaco or for the ISMI for the MICS everywhere Rexis is required. And you beautifully showed how to make a good Rexis with a 1 rupees needle. That is really wonderful. Wonderful, sir. Wonderful, ma'am. Sahu, sir, your comments on that.
Yeah, excellent surgery. Excellent surgery. Wonderful. So you do SICS.
Yes, I
You-
can. I perform my
Yeah.
SICS.
Yeah, you do SICS and the next time you present SICS.
Yes, next time we will prepare next perform
Yeah.
an SICS case.
Yeah, you master it and make 2mm SICS. If you want to have a training, or we can come there, train you, or you can join our courses, and you can visit India. We will train you here. Yeah. Okay.
Yes.
You are a confident surgeon, so you will learn quickly.
Can you switch off your slideshow?
Yeah, if you can just say stop share screen, doctor.
Ah. She is unable to do.
Dr. Neeta, can you do it from your side?
She's not host, sir.
I'm there, sir, but okay.
Can Rahul do?
İşte
Rahul.
spor
Rahul
şey,
Bharat can help us.
Up
şey
here on
gibi.
the upper portion.
Чиний гарч ирээд бусдынх нь шеэр хийхээр харагдахгүй юм.
Stop sharing.
Rahul.
Yeah.
Thanks.
Yeah, it's
Yeah.
done.
Thank you. So,
Yeah.
next, sir, I am coming to you for your final comments on this, since you are the president of the ISMICS.
Yeah, thank you. Thank you, Deepak. So we are really we are lucky and glad that today we opened the Mongolian chapter of ISMS-ICS, and we had a lovely program where the scientific program as well, and the 4 topics which were discussed were really very relevant. And with this kind of collaboration, I am sure, because they have got a lot of, especially glaucoma, angle closure glaucoma in Mongolia is very high, because she also showed the figure, the prevalence. So, and as the age increases, the incidence also increases, the prevalence increases of angle closure disease. So that way it is a good collaboration. But one thing which which bothers me, that in MSICS, we disturb the conjunctiva. And as a glaucoma surgeon, we don't want any conjunctiva to be disturbed. Because in future, you want to have a good, if you want to have a good bleb, functioning bleb, then conjunctiva should be virgin when you operate for glaucoma. So that, I think those Dr. Sahu and Dr. Boramani and all of you should think that how to avoid that completely. Because I know someone from you will tell that we will do temporal incision, but still conjunctiva is disturbed.
No, we are doing a transconjunctival incision also. I think let us see how it goes. A lot of people are doing, and I am also started doing, and see how things will go. So let's see.
Yes, definitely. Once we pose problem, then you people will come forward with the solution.
Thank you, sir, for giving us the new challenges. Now, Dr. Udarma, some comments from your side.
This is a wonderful opportunity to our Mongolian doctors. Also, we will very happy to join this international small incision, manual small incision group. Also, we very happy to glad to meet you, especially and thank you for the glaucoma specialist, Dr. Barun. We always consider, because we have a lot of angle closure angle closure patient also. Also, we like you do the gonioscopy, and they're always most of them is like a primary angle closure patient. It's
Dr.
the difficult. Sometimes it's the difficult to do the cataract surgery because it's the no AC depth. It's the difficult to manage. The FECO also is small incision cataract surgery.
Dr. Mani, sir.
Yeah, I congratulate all the speakers. All the talks were excellent. You Mongolians are doing a lot of good research work, and I think we'll do a lot of collaboration in the future as far as the ISM SICS is concerned. Yeah, and I request all of you to participate in our biennial world conference. Every 2 years we are holding a world conference. So we'll be sending the circulars, and we want lot of participants from Mongolia. Last time Dr. Undarma was there in our conference. So I think she'll bring a lot of delegates and speakers from Mongolia. Thank you.
And one request from my side, that as we are expanding every day, means at least I see opportunity to get more publications in our journal from all the newer friends who are joining us, because unless publications are very high, the number of publications, means we cannot project it very strongly. So that is one of my real concern, that we should not only talk that my results are good, show it with numbers, that's all. Then that world will accept it.
So can I read out the guideline for all chapters?
Yes, sir. Yes. Please, sir.
I'm reading out the guideline for all chapters. Every month there will be a meeting, and each, either virtual or physical, of each member of ISMSICS discussion, publication, and one aspect of MSICS with those students and teachers interested. Second, every 3 months I have to a competitive debate video presentation amongst the students of different institutions. Select 6 students. Every 6 months, 6 students who have been selected will be given one topic to debate, and 3 students will be selected. ISMSICS membership increase drive will also be done. Every 1 year, out of the 3 winners, 1 will be selected, participating presentation and video. This selected student will compete with the similar one. Each student is selected from each foreign chapters. Out of this competition, 2 students will be selected by the international panel of selectors. Those 2 students will be given free scholarship of 1 month training under reputed eye surgeons in India. 1 year activity report will be sent to executive chairman. Best chapter will be awarded during the CCC biannual world conference. Any suggestion or anything is most welcome, but this will be the guideline, so that you remain connected with all the chapters, and the chapters best chapter will be awarded, and student will be given the scholarship. So this will be the same format for India, but with a little change here and there. The foreign chapters will compete with the foreign, because they are not that conversant with SICS. So we don't want to compete with the Indian students. So I think I will send it this guideline, so you carry on, so that the activity remains continuous.
Yes, sure. We will continue.
Now I invite Parikshit sir to give vote of thanks. Parikshit sir.
Yes, we can give a vote of thanks. Deepak.
Parikshit sir.
Parikshit hai?
Sir, Parikshit sir is giving. Yes, sir. Yes, sir. Sir is here. Parikshit sir is here, sir. Parikshit sir, we are unable to hear you. Kindly unmute yourself.
Hello.
Yes, sir. Yes, sir.
No, I think I should. You do the
I think Parikshit sir has a connection problem, internet.
I think he has lost it seems.
Dr. Deepak,
Yes,
you
yes.
go ahead.
Thank you. First of all, I would like to thank Dr. Parikshit sir and Dr. Udarma for coordinating with each other, and from the ISM-ICS, the whole thanks to Amulya Sahu sir, our founder chairman, our executive chairman Boramani sir, under whose guidance we came to this stage in which we have at least the 5,000 members of the ISM-ICS across the world. And under the leadership of our president, Dr. Barun Nayak sir, we are trying to grow more and more, both in the academic direction and the social direction. Hope we will do much more in the future. With these words, me and my co-moderator, Dr. Nita Daud, would like to give heartfelt thanks to all of our Mongolian colleagues and our own office bearers, listeners, and the IT teams, and most important, the sponsor of this webinar in Toad team. Thank you, everyone. Thanks a lot.
Thank you, everybody. It's a wonderful webinar. Thank you, Nita, for conducting it well.
Thank you, sir. Thank you for giving me this opportunity. We'll try to do better. Thank you, sir. Thank you, everyone, for attending and giving your inputs.
So thank you all wonderful people from Mongolia.
Yes, Dharma special
Yes.
thanks.
Yeah, thanks everyone.
Host,
Thank
kindly make us offline.
Yes.
Thank you so much for everyone.
Mhm.
Thank you so much.
Thank you. Yeah.
Thank you for you all.
Thank you.